Okay, well, it is 2:05, so we can get started now. So I do have the recording started. That's one of the things I sometimes forget. So welcome everybody to our session for today, our Learning for Life session. Very excited to hear our speaker today, Dr. Upton Allen, share information with all of us around COVID-19 disparity and why does it exist. It really helps us to have a better understanding when we can understand the basis of where things kind of stem from. And we also have Dr. Klassen with us who will be able to provide some support in French. And so we will first do our introductions and then we'll do a land acknowledgement and move into our session. So I just did up the agenda. Okay, well, you know what? It is, there is an agenda. I'm sorry that you don't see it there. I do have it on my slide. So let me just stop sharing and reshare and see if it's just the wrong one. Yeah, let's go here. Okay, so you guys should be able to see that one now with the agenda, and I'll just go bigger. There we go. Okay, so the session will be recorded, as you guys know, so that it's made available for reference and for attendees who could not attend today. We will mute all attendees to avoid any background noise for the presenters. If you have any questions as you hear the speakers, please use the Q&A or the chat feature to send your questions, and we'll go through as many of them as we can during the Q&A session after, and we don't have a panel today, but after Dr. Allen is done, we then have time for questions and answers. Okay, so we will start off with some introductions of our panelists and our co-moderators today, and we'll then go into our land acknowledgement. We have one of our collaborators supporting our session today, so I want to allow them to just introduce themselves briefly. Excuse me. And then we will get the session started. Dr. Allen will present to us for around 40 to 45 minutes, and then there will be time for questions for 15 to 20 minutes. If we need more time, we can always see how things are going. Okay, so to get started, I'm Karen Fleming. I'm the education coordinator for SCAGO, and I also work at North York General as the professional practice leader for nursing. And so my involvement today is to help co-moderate the session along with we have a great panel today of co-moderators. And so I will pass it on next to Elizabeth to introduce herself.
Hi, everyone. My name is Elizabeth. I'm going to be helping co-moderating this session with our beautiful panelists and along with our other co-moderators. I'm the operations coordinator at SCAGO, and I'm here to just support and be a backhand help. And I guess I'll throw it back to Karen. Thank you.
Thank you. And next, if I can have Abdu, please.
Hi, everybody. My name is Abdu. I'm in charge of relation and engagement with the Francophone community. So at the Center Francophone of Greater Toronto, it's a nonprofit organization with diverse services for the Francophone community. Bonjour tout le monde, je m'appelle Abdou, je suis en charge de relations avec la communauté francophone, et ce au Centre francophone du Grand Toronto, et on offre plusieurs services à la communauté francophone du Grand Toronto. Merci.
I saw his mute there. Thank you very much. Happy that our session does have some bilingual support to it today. So let me get into the land acknowledgement, and then we can go ahead and introduce, there we go, introduce our esteemed speakers for today. So we're grateful for the opportunity to gather, though virtually, on this land, and we thank the generations of Indigenous people who've taken care of this land long before other nation groups came. In particular, we acknowledge the traditional territories of the Ojibwe, the Anishinaabe, and the Mississaugas of the New Credit, whose territory is covered by the Upper Canada Treaties. We also recognize the contributions the Métis, Inuit, First Nations, and other Indigenous people have made in shaping and strengthening this province and this country as a whole. We also need to continuously educate ourselves about the colonial history of this country and understand how the wrongdoing of the past still impacts the present and the future. I encourage everyone at this session to actively seek information and take action. Okay, so now I'd like to And Abdu, actually, thank you very much for introducing your organization. So I'm going to move into introducing, I'm now going to get rid of my slides. I don't feel like I need mine. I'll stop sharing. So I'm going to go ahead and introduce Dr. Allen. Dr. Allen is a professor of pediatrics at the University of Toronto. He is the head of the Division of Infectious Diseases at the Hospital for Sick Children. Dr. Allen is also a senior associate scientist in Child Health Evaluative Sciences program at SickKids Research Institute. His primary appointment is with the Division of Infectious Diseases in the Department of Pediatrics at SickKids. He is cross-appointed as a professor in the Institute of Health Policy, Management and Evaluation at the University of Toronto. We're very happy to have him join us today. And I'm going to allow you, Dr. Klassen, and my apologies, I did not get your bio. I'd like to allow you please to introduce yourself and give us a little bit of a background and bio, because you certainly are one of our great contributors to the field. And then if you can allow, give some information around the French aspect of things, that would be great. Thank you.
Thank you. So I'm a pediatric hematologist at the Children's Hospital of Eastern Ontario in Ottawa. So I'm involved in caring for patients with sickle cell disease in particular. And I've been invited to provide support because many of my patients are French and Francophone, so I speak to them in French. So I'm just gonna, for those patients, for those participants, I'm just gonna give a little explanation about the French component of this. Alors, pour tout le monde qui parle français, je m'excuse, on n'a pas eu la chance de vraiment traduire toutes les présentations. Alors, à ce point-ci, on a seulement le sommaire du présentation en français. Si vous voulez les détails de ça, vous pouvez contacter Karen en le chat. On va mettre le courriel, alors vous pouvez utiliser ça si vous avez des questions et si vous voulez les présentations en français.
Great, thank you. I'm just going to pop my email into the chat. Perfect. Thank you. It's already there. Love it. So that's very helpful. Then, guys, I'll ask our co-moderators. We now can go ahead and turn our cameras off. And Dr. Allen, the floor is yours. Thank you very much.
Thank you so much, Karen, and it's great to see you. And of course, Rob Klassen is an old friend from many years ago. And I will first share my slides. And you let me know if you can see my slides. First, I need to. Great. Can you see that first slide? Wonderful. Thank you so much. Again, it's just a pleasure to be with you today and to talk about COVID-19 and disparities. Now, it's hard to talk about anything to do with disparities without touching on sensitive areas. So some of what I'll say will make us a little bit uncomfortable, but it's important to recognize that to address issues with respect to inequities and disparities, we have to feel a bit uncomfortable at times. But again, we are all among friends today, so that's important. This is an outline of my areas of focus. And I'll come back to this slide at 2 or 3 points during the presentation when I pause to summarize some of the key things that I would have addressed in the preceding slides. And so to begin with, we'll focus on what I would see as 4 main items. First is COVID-related disparities then, now, and why did these disparities happen and why do they continue to exist? And then, of course, I will attempt to put forward some ideas regarding solutions. It's not a perfect world, and if it were, we wouldn't have disparities, but I will come up with what I think are some potential approaches to addressing the disparities, i.e. creating solutions. And so when COVID started in early 2020, we learned a few things right from the get-go. It was really abundantly clear that there were groups of individuals who were disproportionately affected by COVID. And so, for example, in the United States, data generated by the US Centers for Disease Control and Prevention, the US CDC, found that individuals with sickle cell disease, for example, who developed COVID had higher rates of admissions to hospitals, intensive care unit admissions, and mortality. And so this was seen very early on during the pandemic. Now, also emerging at around the same time were data from the UK that showed that individuals of African ancestry were more than twice likely to die from COVID compared with their white counterparts. And this is shown on this slide, where my cursor is on the left is the comparison with respect to whites versus all other racial groups, ethno-racial groups. And if you look at individuals who are Black African, Black Caribbean, they were more than twice likely to die from COVID. And for females, it's about the same, that they were about twice likely to die from COVID. So these were some of the early signals coming out of the UK. And then what about Toronto? Well, we actually saw around about the same time in Toronto, data that were generated that looked at the reported rates of COVID infection by ethno-racial groups. And this slide essentially shows the share of COVID cases within the particular ethno-racial group and their share of the population. Gray represents the share of COVID cases, and the mustard color represents their share of the population. In a situation where the mustard color exceeds the gray color, that's good, because it means that you are more represented within the population than COVID. In other words, you're getting less than your share if you were to look at it that way. Flip side of that, if the gray bars exceed the mustard bars, it means that you're getting more share COVID than your share of the population. So if you look at the white population in Toronto, approximately 50% of the population in July 2020 only accounted for less than 20% of COVID cases. If you look at the South Asian population, 20% of COVID cases, only 13% of the population. And if you look at the Black folks in Toronto, about 20% of the COVID cases, 10% of the population. And if you look at across all the groups, the only groups where the mustard bars exceed the gray bars would be the white population and East Asian population. For all other groups, the gray bars exceed the mustard bars, meaning that they were disproportionately represented among COVID cases. Now, in the United States, similar trends were seen across different groups. And so, for example, here the US CDC summarized data that looks at hospitalization and mortality by race and ethnicity relative to the white population in the United States, and these were rate ratios. And so if you look at the indigenous population in the United States, they were close to twice likely to be represented among cases, more than twice likely to die, and more than 3 times likely to be admitted to hospital compared with their white counterparts. And when you look at the Black African population, non-Hispanics, they were just about the same in terms of cases as the white population, but close to 3 times likely to be admitted to hospital and about twice likely to die. You see rates in the rate ratios relative to the white population for Hispanic or Latino folks are close to twice likely in terms of cases, close to 3 times in terms of hospitalization, and about twice likely to die. So the disproportionate representation was well documented in 2020 and continued into 2021. And these are data looking at the kids in the UK, and here the key was to look at, actually I think this is across all groups, but the key was to look at whether or not individuals had favorable outcomes or unfavorable outcomes according to race. And if you look at the various characteristics such as hospital admissions, how long people spent in hospital, whether or not they went to ICU, and you look at white, Asian, Black, mixed, and others, if you're one, it means that you're not more represented in the group relative to the comparison group. And so the comparison group here for reference was the white population. And so if you look at all the groups and all the outcomes, you can see for Asian, Black, and mixed folks, for the most part, the negative outcomes were among those groups. There were some that were close to 1 or overlapping 1 in terms of the confidence intervals. But if you notice that they lined up on the right side of the graph, which is the unfavorable side, and not much in terms of lining up at all on the positive side, which is the left side of the graph. So again, suggesting unfavorable outcome according to race. Now, if we go further and we look at the United States, and one looks at parents dying from COVID, and you look at kids, for example, and the proportion of US children who were Black, about 14%. But these children, when you look at the proportion of children who lost a parent who were Black, they were 20%. So even when one looks at parental deaths from COVID, these children, they were disproportionately represented among individuals losing a parent from COVID. And I'm going to show you 3 slides that look at race and ethnicity and COVID-related mortality. And it shows various ethno-racial groups and essentially any situation where the gray bar exceeds the blue bar, it means that that's a favorable situation. And if the blue bar exceeds the gray bar, it means you're disproportionately represented in these mortalities. So if you look at in kids who are 0 to 4 years of age, Hispanics disproportionately represented, Black non-Hispanics disproportionately represented, but the Asian non-Hispanic and whites were not. And if you go to the middle age group for kids, 12 to 15, you see the same trend where there are some groups that are disproportionately affected by COVID relative to others. And if you go on, you'll see this in data being generated from various sites. So the question then is, what did we see in summary, looking back at 2020 and 2021? we saw the disproportionate representation of COVID according to various ethno-racial groups. And also, we saw right from the get-go that among certain individuals, including those with sickle cell disease, that they were disproportionately affected among the adverse outcomes from COVID. Now, would not do justice to this topic without mentioning that there are other individuals who are at high risk for bad outcomes from COVID, as defined by the presence of medical comorbidities, such as individuals with underlying chronic lung disease and underlying chronic kidney disease and heart disease, obesity of the really gross kind, a number of other conditions. But putting it all together, there's no question that individuals who were from the Black populations in North America and in Europe, that they were disproportionately affected by COVID. So it might be an opportunity to pause for a minute or so to allow my friend, Dr. Klassen, to summarize some of what I just said, because his French is much better than mine.
Thanks, Dr. Allen. Juste pour clarifier, ça veut dire qu'ils ont trouvé dans plusieurs études que les personnes qui viennent d'Afrique ou qui viennent Sud-Asie ou les Espagnols ont plus de risque d'avoir le COVID et puis aussi d'avoir plus de risque d'avoir hospitalisation, puis être admis à les soins intensifs et puis plus de mortalité. Et c'est dans plusieurs études aux États-Unis, en Toronto et puis aussi aux Angleterre. Alors, c'est pas seulement un endroit, c'est partout dans le monde.
Oh, this is great. Thank you so much, Rob. This is great. So the question then is, why? Why did this happen? And then where are we now? So let's see if we can tackle the why. So the CDC, and this is one of those things that it's hard to talk about without some degree of discomfort. But the CDC tackled this right from the get-go, and they looked at the factors that were contributing to an increased risk of COVID-19 and identified that there are issues related to racism and discrimination, issues relating to access to healthcare and how it is utilized, the types of jobs people had, their educational background, their level of income, as well as housing. And we'll touch on some of these in the next few slides. But this is absolutely key in trying to understand why disparities exist. Now, coming back to data generated from Toronto relating to the why, this was February of 2021, and it shows the share of the population occupied by individuals in different income categories. And so, for example, at the far right, individuals earning 150,000 or more, and at the extreme left, individuals earning less than 30,000. And again, if the gray bar exceeds the blue bar, you're disproportionately represented. And it basically shows that individuals at the far end of the income range, when compared with individuals at the left end of the income range, the individuals at the left end were much more likely to be represented and disproportionately affected by COVID compared with their counterparts earning more than $70,000. So that's, one of the whys. And in fact, going further, looking at different quintiles or categories of material deprivation, which is a measure of how well we are off in terms of resources, including financial resources. Individuals who are least deprived, i.e. the ones who are better off, are at the top here, and the most deprived would be at the bottom. So 1 would be better than 5. And as you can see, as if you look at the number of cases, the more deprived you are, the greater the number of cases. And that was, if you look at the age groups, you can see the age groups, but I think the main point really relates to the number of cases tracking along with how deprived you were, suggesting that socioeconomics had something to do with the why. And then, so as not to focus on just Toronto, and remembering that Toronto is not the center of the universe, although we like to think that is the case. But if you look at the region of Peel, and you look at various groups of individuals, again, looking at the comparison of different bars. Here, if the blue bar exceeds the gray bar, you're disproportionately represented. And you can see that the South Asian population is the group that is disproportionately represented among COVID cases in the region of Peel. And so this is a big deal. So again, that disparity, the disproportionate representation seems to span ethno-racial groups and seem to be aligned with the earning potential of various individuals. And if you go back, go further and look at the why in more detail, in the Peel region, what was really quite clear was that the individuals who were most represented among COVID cases between early 2020 and the end of 2020 were people who were on the front line, so to speak, in terms of the types of jobs that they did. Tradesmen, people in sales, healthcare workers, they were more likely to be represented among COVID cases. And then individuals who were not regularly documented within the labor force, they were also significantly affected by COVID. So again, giving some ideas then of the why. And so again, coming to a summary point that where Dr. Klassen, my friend, will help, we're seeing that the why relates to socioeconomics. It relates to the types of jobs that people are doing. Frontline jobs were jobs that put people at risk. We know that there are various reasons why individuals are in the types of jobs that they do. And in some situations, it was clearly documented that there are individuals, for example, some personal support workers who had to do 2, 3, 4 jobs just to make ends meet, doubling, tripling, quadrupling their potential exposure to COVID. And so with that, I will pause and Dr. Klassen will summarize some key points.
Thank you. Alors, Dr. Allen a expliqué, on essaie de mieux comprendre pourquoi est-ce qu'on a cette différence entre les Blancs et puis les patients qui viennent comme de Sud-Asie. Alors, on essaie de, c'est à cause de les salaires, ceux qui ont les salaires bas, et aussi on voit avec les métiers qui sont en contact avec les personnes, plus de contact avec les personnes, c'est eux qui en particulier ont plus de problèmes avec COVID et qui devient COVID positif et les admissions. Alors ça, c'est une des explications pourquoi on voit beaucoup plus de COVID dans les personnes qui viennent de Sud-Asie puis Afrique.
Great. Thank you so much, Rob. Much appreciated. So where are we now? 2021, 2022. Where are we now? So if you look at Toronto at the end of December of last year, it's really good news for many reasons, but it was a lot of effort directed at trying to fix the problem. And here, remember that slide that I showed you where white population accounted for close to 50% of the population, but less than 20% of the COVID cases. You can see the gap change a little bit, things balancing out a bit. If you look at the Black population, you remember there's about 21% of the COVID cases, just close to 10% of the population. The gap was narrowing there. Overall, still, we had the two populations where the mustard bar exceeded the gray bars, the white population and the East Asians. But definitely, there was improvement. And certainly, if you look at the Black population, you can see that the gap was closing. And this is really thanks to the efforts of many individuals who had identified that the data pointed to an issue that needed to be fixed and stepped out front to try to fix this issue. But we know that despite the fact that improvements are occurring, there's still work needs to be done. If you look at the United States, from early 2021 and COVID vaccines became available, you can see a progressive increase in uptake of the vaccines across the different racial groups in the United States. If you follow along with me, you can see the Asian population and the white population. The Asian population vaccination rates took off, continued to climb, and way up, as you can see, by the end of 2021. The white population, vaccination rates, somewhat lower trajectory, and then Hispanics, an even lower trajectory, and then the Black population, the lowest trajectory. So there's a gap between the races in terms of vaccine uptake, and it points to the need for more work to be done, because if indeed we're saying that across North America, Blacks and Hispanics are disproportionately represented among COVID cases, but when you look at the gap that exists between those groups and other groups with respect to vaccine uptake, there's a problem. It means that we need to do more work to fix the issues. And so with that, again, what I will do is that I'll pause for a brief moment before getting into the final segment of the presentation that focuses on solutions. These are some of my ideas, but ideas shared by others as well. But maybe I'll pause and turn it over to Dr. Klassen once more.
Yeah, thanks. Alors, ce que Dr. Allen a mentionné, c'est que les choses améliorent. Alors, en Toronto, en décembre 2021, ils ont vu qu'il y a moins d'infections proportionnelles pour les Noirs et les personnes sud-Asie que les Blancs. Alors, ça semble que les choses commencent à améliorer. Aux États-Unis, on a ce qu'ils ont trouvé avec les vaccins, c'est que les vaccinations avec les personnes qui viennent d'Asie sont d'excellents, 75%, mais ça diminue avec les Blancs, les personnes hispanique et puis aussi le noir, c'est 50%. Alors, c'est pas aussi bon que les autres nationalités.
Great. Thank you so much, Rob. You know, there's no perfect solution. But in thinking about this, I have, you know, come up with the thought that maybe we need to focus on about 5 different strategies, or that might be bundled together and over different phases. And so, you know, the phases overlap, but I thought perhaps the first phase was information gathering. And in fact, in that regard, it's really important to generate data from the affected communities. It's only by identifying the challenges that will we be able to fix the issues. And so I showed you the data of from July of 2020, showing how the Black population was disproportionately represented, how the South Asian population was disproportionately represented, Hispanics in the United States. It's that data that one needs to be able to fix things, to bring about a change that I showed you in the more recent slides, and summarized also by Dr. Klassen. But what it means is that we have to participate in the data gathering process. We need to encourage the powers that be to allow for disaggregated data and race-based collection of data. But we do need to participate in the data generating process. And often we run into situations where people say, well, no, I'm not taking part in this study. I'm not doing, nobody's gonna do a blood test on me or what have you. But unless we take part, we will be left out. And so we recognize the importance, though, that when data are being collected, that such data are collected by individuals with whom individuals have had a relationship that is built around trust. And so it might be an opportunity, I think, Rob, to just summarize this one. I'll leave this slide up.
Oui, alors, c'est quoi est-ce qu'on peut changer la situation? Alors, une des choses les plus importantes, c'est d'avoir d'informations. Et pour avoir information, il faut que les personnes, il y a de participation. Et sinon, on n'est pas on n'a pas l'information pour mieux comprendre comment améliorer la situation. Et pour que ça arrive, il faut que les personnes ont la confiance dans les personnes qui prennent l'information. Alors, sans confiance, on ne va pas participer.
Great. Thank you, Rob. So the next phase, and again, these phases overlap, is that it's really essential to ensure that people who are providing information to various communities, they themselves are well educated and know the facts. And so we and my colleagues and I, Isaac Adamis, who you know well, and we have started a program to educate educators so that they're better equipped to spread correct information to the community at large. It's important that these individuals work with persons and groups who are trusted and among the most well-connected within the communities because of this long history of trust. With respect to one area, for example, issue of vaccine, which I'll mention in the next slide, somebody asked me once, what would make me lose sleep at night with respect to vaccine, the COVID-19 vaccines? And I say, well, I would lose sleep if I knew that somebody when faced with a decision regarding whether or not they're going to be vaccinated, chose not to be vaccinated based on wrong information. And as an educator, as a physician, I would feel really bad. I would feel that I haven't done my job adequately, so that somebody would refuse to be vaccinated because they felt that an mRNA was going to change their DNA, or that somehow the mRNA was going to remain in their system for, you know, an indefinite period of time. These are things that would be really sad, because we know the answers, and so we need to ensure that people who are educated in the communities, they themselves are well educated. And again, I'll turn it over to Dr. Klassen.
Oui, alors pour changer la situation, c'est important que l'information qu'on a, c'est précis. Alors on ne veut pas, et Dr. Allen dit que ce qu'il ne veut pas, c'est les personnes faire des décisions à propos des vaccins parce qu'ils ont l'information qui est imprécis, qui est incorrecte. Alors ce qu'on veut que c'est, si on fait des décisions, il faut avoir toute l'information avant de vous pour faire la meilleure décision possible.
So thank you. And so talking about these strategies, the third step is a recognition that one needs to start a process of addressing various barriers, and that one needs to engage a community. Now, one appreciates that barriers within the communities do take time to be dismantled. You can't fix these things overnight, but it's really important to identify the resource needs that are required to address these infrastructural issues. And one should start the ball rolling with respect to addressing them, because as I've shown you, this slide that summarizes the data from the CDC, that it was really quite clear that there were demographic and socioeconomic factors that drove some of the disproportionate representation of COVID among different ethno-racial groups. And so, Dr. Klassen, I'll appreciate your summary again.
Oui, alors il faut identifier les barrières qui contribuent au problème. Si on vraiment trouve ce qui cause les problèmes, comme ça on peut identifier les solutions.
Now, I'd like to thank you once again. I'd like to mention a few things about vaccine and information gathering. Again, it's so important that one ensures that adequate information is provided by trusted individuals, and that when one addresses access to vaccines, this is viewed through an equity lens. We need to take into account the special needs of children across various ethno-racial groups. And then once vaccine has been rolled out, the data gathering is important to ensure that there's equity in distribution. And so if you look at that slide that I showed you about vaccine uptake in the United States, you could say, well, how do we know that the lower trajectory seen among Blacks and Hispanics isn't due to the fact that they don't have great access to vaccine? That maybe it has nothing to do with how willing they are to be vaccinated. Maybe there are access issues. Maybe there's a combination of factors. And indeed, in the United States, that was one of the issues, where individuals were saying, well, I'm interested in vaccinated. I'm not bubbling in enthusiasm, but I'll be vaccinated, but I'm not going to join a line if I'm going to have to spend hours in a line. you know. So, and we encountered some of that in Ontario. So again, one just needs to think about it in terms of the equity lens. And so taking vaccines to where people work it would be just one example of addressing the equity perspective as this relates to vaccination. Dr. Klassen?
Oui, alors, une des choses, si on voit qu'il y a des problèmes avec la vaccination, c'est de mieux comprendre pourquoi il y a une différence et pourquoi il n'y a pas d'égalité entre les groupes ethniques. Et alors, une des choses, comme ils ont trouvé que si dans les régions où on produit, où on a les vaccins, et les lignes sont très longues, les personnes ne vont pas aller avoir le vaccin. Alors, il faut changer ça pour que les personnes qui sont dans des communautés où ils s'inquiètent un peu à propos du vaccin, on met que les lignes sont on n'attend pas trop long pour avoir le vaccin.
Thank you, sir. Appreciate it. And then finally, what I call the fifth phase, again, these are overlapping phase, is that when one is dealing with inequities and one identifies that there are structural barriers that lead to disproportionate representation of various groups among, as this relates to different health outcomes, one of these is COVID-19. Once resources have been identified, it is important that one continues to address these resource needs, and one needs to consider the factors that contribute to overrepresentation of medical comorbidities among Black and racialized groups. Why is it that these individuals are overrepresented? There are some disease, that might be related to genetics. Sickle cell disease is one of those. But COVID largely has been driven by socioeconomic factors. Research is being done to understand whether or not there's some genetic components. So the verdict is still not in on that. But certainly what we see staring us in our faces are factors that relate to how people access healthcare, where they work, how much they earn, their level of education, issues around frank discrimination. All of these are issues that need to be addressed moving forward if we want to reduce the chances that these groups that are disproportionately represented now will become disproportionately represented in COVID 2025. Hopefully there isn't such a thing, but you get my point, that we have to fix these issues even after COVID-19 disappears from the scene. Dr. Klassen?
Oui, alors il faut vraiment trouver les barrières et déterminer les ressources qu'on peut utiliser pour diminuer les barrières. Et on trouve avec COVID, c'est plutôt les facteurs socio-économiques qui causent la plupart des problèmes. Alors, avec ça, on peut essayer d'utiliser les ressources les meilleures possibles pour diminuer ce problème pour maintenant, puis aussi dans le futur, dans 2025, s'il y a une autre pandémie qu'on ne veut pas, bien sûr, on veut pas, mais il faut qu'on est prêt.
Dr. Klassen, thank you so much. And I really want to thank you all for having me this afternoon. I will stop sharing my slides now. It's again, a real pleasure to have this opportunity to speak with you. And I'd be happy to take any questions. Thank you so much.
Thank you, doctors. Thank you, Dr. Allen, Dr. Klassen. It was very instructive. And we have one question It said, why is it so difficult to access a non-mRNA vaccine in Toronto?
So why is it so difficult to access non-mRNA vaccines in Toronto? So that's a really great question. If you remember, when the vaccines were rolled out initially, we had four vaccines in North America and Western Europe. We had the AstraZeneca, Johnson & Johnson, which are non-mRNA vaccines. And then we have two mRNA vaccines, Pfizer and Moderna. There were side effects such as, clotting, an increased risk of clots with the AstraZeneca and Johnson & Johnson vaccine. And that led to the decreased uptake of those. In fact, those were just not being distributed in Ontario. And so we're using Moderna and Pfizer, which are the mRNA vaccines. And so that has continued. Fortunately, two new vaccines are appearing on the scene. I was about to say have appeared, but they are not quite yet available for widespread use, although they've been approved. And these are the Novavax, which is a protein subunit vaccine. And then we have, again, non-mRNA, and a Medicago, a plant-based vaccine. So we do have non-mRNA vaccines. They're just not ready yet. And I think it's just, the question is why they're not available. It's just a supply issue at the moment.
Okay, I hope it answered your question. Is there any other question?
It seems that someone has their hands up, actually. Sherman Moore actually has their hands up. Did you want to send in your question or type it in the chat for us?
While the person is thinking of their questions, I want to come back to the issue of data generation. So one of the things that we're doing in collaboration with SCAGO is to look at how people who have been vaccinated have responded to the vaccines. It's not a study that we're doing to say, okay, now go get vaccinated so that you may be tested, but rather, if you have been vaccinated, we can enroll you into a study that will allow you to determine, did the vaccine take, how well you have generated antibodies, and also another aspect of the immune protection, which looks at cell-mediated immunity, which Dr. Klassen and I would be more familiar with. So antibodies, cell-mediated immunity, and then we can follow individuals with sickle cell disease over time to see if they maintain the antibody levels. And so that is something that we're doing. And in fact, when it's done in the communities, we not only include individuals with sickle cell disease, but we include all individuals who've been vaccinated, regardless of race. So happy to take any other questions that you have.
Sorry, Upton, just to clarify that, is that going to be specifically for sickle cell disease patients, or is it for all patient populations, or is it the population in general?
Yes, that's a great question. It's primarily targeted at the sickle cell disease population, but we have a companion study that is targeted at the general population. And one of the reasons, Rob, is that let's say we wanted to generate data from the sickle cell disease, data that are relevant to the sickle cell disease population. The only way you can, generalize is to get sufficient numbers. And so you have to structure your sampling so that you get adequate numbers of individuals with sickle cell disease. Similarly speaking, if you wanted to get adequate numbers of individuals, Black or South Asian, you have to specially target those communities so you get sufficient numbers for there to be meaningful conclusions drawn. Yeah. So one of the we're going to be coming to Ottawa actually, Rob, to do some work with Dr. Hugo Luemba at Montfort, and we'll have individuals from all racial groups participate. It's just that we are making a special effort to bring out the African Canadians so they get enough numbers to draw meaningful conclusions, because the African Canadian population in Ontario is only 4.7%. So if you do the average study of 1,000 people, you're only going to get 47 votes, unless you make a special effort to oversample and bring those participants out.
That's great to hear. I'm honestly glad to hear about the advancements that are happening and seeing the takes and the opinions that you guys are speaking about and are sharing today. There are some more questions that have popped up in the chat, as well as in our question portal. I will read the one in the chat because it was from a participant who had their hands up. They asked, will there be easier access to centralized trusted info and/or educators at some point?
That's a really great question. I believe that such access exists at the moment, but we need to advertise more. So, for example, one of the things that the city of Toronto did was to set up the Black Scientist Task Force on COVID vaccine equity. I wish we didn't have the word vaccine in there, because we focus on more than just vaccine, but COVID-related equity in general. So myself and Isaac Adami, we sit on that. And so we're available to work with individuals to provide them with information from trusted sources. We also have special sessions that we call STEPS, specially targeted educational programs, co-chaired by me and Isaac. And basically, we give seminars to various groups of individuals, not just, individuals with sickle cell disease or Black individuals, but individuals representing specific, constituencies of folks, so that we can have a much more, small, structured environment that provides an opportunity for people to ask questions and get their questions answered.
That's amazing, and I'm glad. I hope that answers your question, Sherman. If you have any more questions, again, please feel free to pop them into our little portal, or if you just want to share them in the chat, I will ensure that they are read out. I also see that Dr. Klassen has answered one of our questions in the portal. As of now, if anyone does have any questions, feel free to share. This is the time for you to, get those questions out that you've been wondering. We have some incredible educators here who are very, very, very well versed in their studies to answer your questions. So please, if you have any questions, please let them be known and see if you can. Oh, there was a study that was spoken about earlier, and someone is asking if there's a way
Yes,
to be a part of it.
that's a great point. So there are a couple of ways that you could find out. One is if you link with SCAGO, you know, the SCAGO will plug you in. The second is that if you Google SERO MARK seromark.ca, it will give you a hit that will lead it to us in some way. So seromark.ca, you'll get a hit and it'll take you to us. But SCAGO will certainly plug you in.
I hope that answers your question.
How did I spell Seromark? Because I tried it, it didn't work.
Yeah.
SEROMARK.
Oh, I tried that, it didn't work.
It didn't work? Okay. How about if you type COVID, COVID, Seromark? Let's try that. No?
Yeah, immunity Seromark?
Yes.
Yeah, okay, yeah, that worked.
That works. So COVID Seromark, and it'll take you to us, and we'll plug you in. Thanks, Rob. Okay.
Dr. Klassen, if you have it live on your screen, I would love it if you can take the link and just pop it into the chat.
Will
That
do.
would be very well. Thank you so much. Again, this is our time for our questions. So we'll just open up the floor for anyone who has any questions to let it be known. Thank you again, Dr. Klassen, for popping the link in the chat. I think to kind of gel or to kind of, fire up some people's questioning spirits, I think I can prompt a question actually for you, Dr. Allen.
Sure.
I know you spoke about the importance of educators, especially the removal of miseducation. And I wonder what you felt the flow of miseducation has been in terms of how it was at the beginning of the pandemic versus now, how you feel as though the flow of miseducation has either gotten worse significantly or has been subdued significantly. So I wanted to know your opinion about how you think as a community we've tackled that kind of miseducation front, and how you think we can go forward in tackling miseducation as a very, very rampant issue that we see.
Yes, a really great question. There's no question that things have improved, but I can tell you that I had an opportunity to interact with several individuals across, different strata of society and different racial groups, and I came across Eastern Europeans who had some misinformation. I came across folks from the African continent. I came across Americans, and I came across West Indians, including my fellow Jamaicans, with lots of misinformation. And how do we fix that? It's trying to ensure that we create the opportunity for people to get their questions answered, and to communicate things as clearly as possible using trusted voices. Trying to explain to people, for example, why is it that an mRNA vaccine cannot influence your DNA, sometimes requires using some simple analogies and one that I often think of is like a peach. And I say, you know, your DNA is locked inside the nucleus of our cells, and that's like the hard seed of that peach. That's where the DNA is locked in. The mRNA enters the outer part of the cell, the fleshy part of the peach that you eat. And there's no way the mRNA can get into that locked vault. It doesn't have the key to get there. So there's no way that it can get there. And so trying to break it down in a way that people can understand is really important for us to continue to do. We definitely have seen improvements, no question. But we do know that there are still some people who are locked into some views that do require a lot more effort to get them to change.
Yeah, no, I'm glad to hear that really in-depth look into it. I agree. I do think there has been, you know, of course, some advancements. When it's good to see and to hear specifically how your take on it. And I would also love to hear, because we've gotten some questions in the chat portal. Cheryl Prescott actually asks, can you tell us more about antiviral treatments, i.e. Paxlovid, and how best to communicate about eligibility and access in the Black community?
Yeah, that's a really great question. Okay, let me step back a little bit and talk a bit about Paxlovid, and then we'll talk about access. Paxlovid is a great drug, but there's a but, and the but is that their drug interactions triggered by one of the components of the drug called ritonavir that potentially interacts with other medications that you're taking. So if you are not on any other medication at all, then there's no issue at all, Paxlovid. If you are on other medications, you must connect with your doctor and ensure that your doctor is aware of the drug interactions. And I can tell you, earlier this week, I tried to get somebody I know who used to work with me years ago, who is clearly eligible for Paxlovid, and just couldn't get on it, get it prescribed, simply because they were on other medications that would need to be adjusted. And so that was an issue. So I think that is the first hurdle to be overcome. But there needs to be more work done, though. I think it's a great question by Cheryl. There needs to be more work done to ensure that there's access to Paxlovid across various communities. So access involves three components, I think, with respect to Paxlovid. Number one, you have to get it to the pharmacy in the communities. Number two, you have to ensure that the people who are going to prescribe it have a easy way of knowing what medications you're on, and that they themselves are knowledgeable about the drug interactions. That is going to be so important. And number three is that you want to be able to ensure that you don't have to wait 3 days to have access to this medication. The person who I tried to get Paxlovid for earlier this week was trying. This was on Wednesday, and they were trying on Tuesday to get it. They couldn't get it. I managed to hook them up with somewhere to get it, but this was Wednesday afternoon. That's 36 hours later. That's not the way the medication was designed to be used. It was designed to be used right away. So clearly work needs to be done, getting into the pharmacy, getting people assessed quickly so that they can get it on board, and then knowledgeable folks about the drug interactions. More work needs to be done for sure.
Can I just add to that? I'm not an infectious disease expert, but just because I know there's a couple of questions on kidney disease, and the only reason I know a lot about it is my wife's a transplant nephrologist and is actually the division head and is dealing with this quite a bit. And so I think Dr. Allen sort of highlighted the fact that initially people were very concerned because about the drug interactions. So you need to have somebody who's really knowledgeable. So, but once you have that knowledge and you know what to do, then you can use those drugs even in the situation of renal failure and renal disease. In fact, those patients are at such high risk of complications from COVID. They're the ones who really need it. So that, and I think I just wanted to emphasize what Dr. Allen was saying.
Yes, that's a really important point.
Yes, thank you so much for that, Dr. Klassen, that input.
I wanted to make a comment too, as well, if I could, for a second, Elizabeth.
Of course.
At North York, one of my roles is having to teach staff about medications and how to administer. So actually, very recently, we talked about this medication and the fact that you also have to actually have some health literacy on how to take the medication beyond exactly how Dr. Allen was referring. The way in which you take it, you also have to understand. You take a different dose in the morning. It's all laid out, but you have to understand, what dose is your morning pack, this dose is your night pack. And so I had to create just a quick visual for nurses to make sure that when they're doing teaching with patients, that information is passed on correctly. So I just think that adds another layer, is that if you're not able to even, you got the medication, but now do you take it correctly? Is this something else that adds to those disparities?
Yeah.
I agree. It was well said. And just to top it off with our last question, and I know that you kind of covered this, Dr. Klassen, a little bit, but someone stated, while I was sick with COVID, the COVID doctors told me that I could not have the treatment protocol pills because it would have a negative impact on my kidneys. The COVID clinic doctors sent me an anti-inflammatory puffer instead. So I think I would love to hear your kind of input on this, Dr. Klassen, and especially you, Dr. Allen, about, I guess, how to kind of navigate the situation that this person was experiencing.
Yeah, I'm happy to start. It's a really, there are different angles that you can take on this. Let me use it as a teaching moment with respect to vaccines, for example, that we'll often hear people say, I didn't get vaccinated because I have kidney disease or heart disease or liver disease, and I was really worried that the vaccine was going to affect. It doesn't affect any of those at all. Really important. In fact, it's individuals with those underlying issues who are at the greatest risk of having a problem from COVID. And then on top of that, if they do get COVID, navigating treatment can sometimes be challenging because you really need to make sure that the treatments that they're getting are not going to interact with other medications that they might be receiving, or if there are any dose adjustments that need to be made because of underlying kidney disease or liver disease, that we can do that. But that said, we are aware that individuals with underlying conditions like kidney disease can be treated effectively, as Dr. Klassen says. You kind of just need to make sure that they're being handled by knowledgeable folks who know how to adjust the medications accordingly.
Yeah, and I would love to hear your input about it, Dr. Klassen, as well.
Well, no, I think what Dr. Allen said is exactly correct. That the people who are the most worried about things like the vaccines and are the ones who need it the most. And so it's always a trade. The one thing I always tell my patients, it's always, you know, I think the media, because they tend to fixate on the small potential, there's this whole question of heart inflammation, for instance, and pericarditis. It's incredibly rare, and it's much less common in people who are vaccinated than people who get COVID. And we now know that COVID is everywhere. So it's roughly 50% of the population has got COVID. And I've had COVID. I'm sure half of the people on this call have had COVID. And the problem is you can get it again. But people don't spend enough time talking about all the problems that happen from COVID itself. So it's far more likely to get sick or problems from the disease than the vaccine. The vaccine is incredibly safe. And so to me, the very first thing is make sure you get vaccinated. So that's the number one thing. And then with the treatments, and now the treatments are much better than they were, at the beginning of the pandemic. Now they have very effective treatments to prevent you getting very sick. But as Dr. Allen was saying, they're just a bit more complicated. They're not just like prescribing, an antibiotic. You have to watch about these interactions. So you just need to have the right people who, know the right treatment from the infectious disease part, and also from your, if it's a kidney problem, having your kidney specialist involved too. It's helpful.
Thank you so much. And if you could give us short a summary in French, I would love that for our French viewers as well.
OK. Il y avait beaucoup de choses qu'on a parlé. Alors, une des choses, juste au début, ils ont parlé de les vaccins, pourquoi il n'y a pas les vaccins pour qui n'ont pas le mRNA. Je ne sais pas en français, mais le problème est, au début, le problème, ces vaccins ont causé des caillots. Alors, à cause de ça, celui qui n'était pas Pfizer ou Moderna, il y avait des problèmes avec les caillots. Alors, ça, c'est pourquoi c'est plus difficile pour trouver ces vaccins. L'autre chose qu'on parlait, c'est accès aux les personnes qui ont des maladies comme avec les reins ou avec le cœur. Ils s'inquiètent à propos des vaccins, mais c'est eux en particulier où c'est le plus important qu'ils reçoivent les vaccins parce que eux, les complications de COVID sont beaucoup plus élevées que les personnes qui n'ont pas ces maladies. Et les traitements qu'on a sont beaucoup plus efficaces, mais il faut avoir les personnes dans l'équipe qui vraiment connaît la maladie qu'ils ont et puis aussi les médicaments pour mieux comprendre comment donner ces médicaments.
Thank you so much. Thank you so much for that. And I think our last question, it seems to be our last question of the webinar actually, comes from Elvis, and they actually have their hands up as of now. The question was actually, what is vaccine confidence for our children? So I'm guessing they're kind of wondering what that kind of looks like for our children. If there's any specificities or anything that I left out of that question, Elvis, feel free to let me know in the chat and add it to to your roster of questions. But as of now, I think we'll kind of just touch on that question that they asked. So what is vaccine confidence for our children? What does that look like? And I guess how can we kind of tackle that, especially with children? What are your inputs on that?
I think it's a great question. Let me focus on 2 or 3 things. It's clear that among children, the individuals who are at the greatest risk of having a bad outcome or bad outcomes from COVID are individuals with weakened immune systems, the so-called immunocompromised individuals. That's point number 1. Point number 2, unfortunately, when we looked at the data across Ontario of vaccine uptake among immunocompromised children, it was really not good at all. And so this is a situation where the group that was at the highest risk of having bad outcomes was not being vaccinated at all. And so vaccine uptake in children could be better. And we need to do more work in that regard. We see lots of kids who have had 1 doses, and parents will say, well, you know, I just gave them the 1 dose. I think that's all they need. And that's not true. And we've seen, you know, some individuals who have had a couple of doses, and even a fewer number with 3 doses. So work needs to be done to improve uptake within the pediatric population. We recognize, though, that there's a lot that families have to unpack to understand what's going on with vaccines in kids and why we vaccinate children. In fact, why we vaccinate adults. And perhaps the medical scientific community, Rob, I think as a group, we probably haven't done the best job in educating the public as to what exactly we're trying to prevent when we give people COVID vaccines. Because I think the public, I think, is thinking that, well, you know, the way that COVID vaccines protect us is like measles. You get measles vaccine, you don't get measles. You get the chickenpox vaccine, a couple of doses, you shouldn't get chickenpox. You know, it's like that. In the case of the COVID, it's not like that. In fact, even with the chickenpox vaccine, I often say when we vaccinate individuals, we vaccinate them to prevent 3 outcomes. Number 1, you want to make sure that they don't die from the illness that you're protecting them against. Number 2, that they don't get severe disease. And number 3, if they get the illness, it's mild. And so I think for COVID, we just need to let the public be aware that the COVID vaccines are aimed at preventing 3 outcomes: mortality, and all the vaccines are very effective against preventing mortality. Number 2, severe disease, and they're all very effective. And number 3, in an ideal world, you want to ensure that if people got vaccinated, they never got COVID, but they may still get COVID. But the important point is that if they do get COVID, it is mild. And so the COVID vaccines then, in summary, are aimed at preventing severe disease, moderate to severe disease, and mortality. That's what they're aimed at. And that's perhaps a way to think about it, and messaging it to the public.
Thank you for that.
One
Go ahead. Okay. Sorry.
One thing I just add is that I think we're a bit of a victim of our own success with children at the beginning when there wasn't vaccines available for children. We had very worried parents on our hands, and we'd say to them, oh, COVID is mild and overall is very mild in children. And we kept giving that message, and because they didn't want to have their children go to school, they didn't want to. And then then the vaccine comes out and they say, well, you told me COVID was mild in children. Why are you telling me to get the vaccine? And so I can understand that kind of, so yes, overall, COVID is a mild disease in especially young children, but still there's a small group who can get severe illness. There's actually a really good study, Dr. Allen, you'd know this better. I think it was in Denmark, where they showed that it's roughly about 0.5% of children will get admitted to hospital. So, you know, less than 1%, and then you know, severe disease is about 1 in 1,000. So it's actually fairly uncommon, but it still can happen. So and the good thing is, at this point, we know the vaccines have been used in billions of people, And so we know the safety profile. So then when you've looked at, you've got billions of people and really no significant outcomes. And yet we know that you have, less than a 1% chance, but you still have that chance of having your child getting admitted to hospital potentially and potentially getting very sick. Again, it's always the risk benefits. The risk of the vaccine is so small, whereas the benefits are actually quite clear.
Yeah. Thank you, Rob. Yeah.
Yeah, thank you so much for that. Obviously, this has a great answer. Thank you, Dr. Allen and Dr. Klassen. That concludes our question and answer portion of the evening. I will throw it over to Karen to kind of give our closings and thank our guests as well as our participants for coming.
Thank you.
Karen, you can go ahead.
Thank you. Sorry about that. So thank you, everyone, for joining our session. Sorry, I'm just reading a couple other things coming in. What is the situation of our Francophone community? So I don't know, did we answer that question? I'm sorry. I don't think we did we?
We did, and it just kind of popped in last minute, yeah.
Oh, thank you. Okay. Sorry. Thank you very much. You know how it is trying to balance, the at-home thing while you're doing multiple. We've all experienced the online situation. So again, thank you everyone for joining our session today. We will have it available online shortly. It'll only take a few days really for us to get the link available online so that you can watch back. And then those that were unable to make it can certainly view back the session. I would like to thank our speaker today, our speaker and support, Drs. Upton Allen and Dr. Klassen. Thank you very much. We are very honored to have you today. And it was a wonderful presentation. A lot of visual things for me that really clicked. And I like the visual pictures, more deprived, more COVID cases, socioeconomic status, lots of things, lots of words that came out for me, positive outcome versus negative outcomes. This helps to paint the picture. So thank you very much. It helps to explain the story. Sherman, it's great to see you, by the way. I see you. So guys, thank you all again. And then Abdu, thank you for joining. Elvis, I know you joined a little later. Thank you as a co-moderator. Elizabeth, thank you as well. And guys, we'll see you again. We'll have another session next month.
Thank
Take
you.
care.
Thank you.
Bye,
Good
guys.
weekend.
Thank you,
Take
Rob.
care, everyone.
Good to see you all. Take care. Bye-bye.
Bye-bye.